Okay, good afternoon, everyone. Welcome, and thank you for joining our webinar today. My name is Brittany Quemby, and I'm part of the marketing team here at Nightingale, and I'm joined by Andrea Rennie, Manager of Healthcare Consulting at Cirrus Consulting Group, who will be co-presenting today's webinar on billing optimization. Today's webinar will cover several learning objectives, including proven ways to increase income in the FHO funding model, tips and tricks to grow your income and combat any MOH changes that may reduce your pay, techniques to decrease your outside use, effective methods to billing outside the basket, strategies and tactics to optimize the many premiums and bonuses available. So a little bit about Nightingale. Nightingale is Canada's leading cloud-based EMR company with over 12,000 providers using our system. People choose Nightingale because we have a secure system, a robust system, and we are a proven leader in our industry. We offer personalized workflows, company stability, and we have pricing that works for our customers. So one thing to note is that this webinar is not a Nightingale demo. It's second in our series of online educational events. And our goal is to provide useful information on relevant healthcare topics from industry experts. Our next webinar, which is also co-hosted by Cirrus Consulting Group, is on effective strategies to managing outside use, which will take place on September 25th at 12 p.m. For any additional information on this webinar or to sign up for our future webinars, you can contact either Cirrus Consulting Group or Nightingale with the information that appears on your screen. So at this point, I will now pass the reins on to Cirrus Consulting Group. The presenter today, as I mentioned, is Andrea Rennie, Manager of Healthcare Consulting. We'll have a brief Q&A at the end of the webinar, so please leave all your questions until the end. All your questions can be typed into the chat box that you have on the right-hand side of your screen. We will do our best to answer all the questions at the end of the webinar. However, if we do not get to your question, don't worry. We will be following up to answer any of the unanswered questions by email. So at this point, I'll pass it on to Andrea.
Thank you, Brittany, and thanks everyone for taking the time out of your day today to join us on the webinar for billing optimization. And a big thank you to Nightingale for sponsoring the event today. Let's get started. So some quick facts before we jump into things. Just want to highlight a few key pieces. One thing is that the family physicians are now better compensated in Ontario than anywhere else in Canada. More than 75% of all physicians say their pay does not align with the care that they deliver. Ontario physicians are generally not strategic in how they are paid due to widespread lack of clarity around the OHIP funding model. I think a lot of this has to do with the fact that there was such rapid change that happened within the last 10 years. You think even 10 years ago we were still just working within the fee-for-service mindset, and now we're into things like patient enrollment models, we're dealing with outside use, access bonus, preventative care. So many different layers have been added in so quickly. It makes sense why there's a little bit of lack of clarity sort of around how to take advantage of what is available to you. The purpose of today's program is to increase your understanding of the FHO and FIG models, understand where your practice income comes from both within the FIG and the FHO revenue streams, and to optimize your income within both models. A little bit about Cirrus Consulting Group before we get started. We were founded in '94. We have 50 employees headquartered in Toronto, and we provide practical business solutions that allow healthcare providers to concentrate on what they do best, which is provide quality patient care. We do that through two of our specialized business units. The first, which is our office lease negotiation department. We do over 500 office leases for medical practitioners all across North America per year. From there, we also have our healthcare consulting division where we offer billing, support, and operational consulting for physicians, for both groups and individuals. So we help physicians and staff optimize income, increase efficiency, and flexibility. What we don't do is teach people how to overbill or improperly bill or try to gouge the system in any way. What we're trying to do is close the gap between the work that you provide each day and what exactly you're being paid for. Clients include physicians and office managers operating in all models, FIGs, FHOs, and FITs. We work with both groups and individuals. And doctors leveraging Cirrus services see an average income increase of between 15 and 25%. And the hours saved by engaging Cirrus as a group of physicians is approximately 1 full-time work week per month. We've assisted 672 healthcare practices across Canada and established a collaborative relationship with over 2,100 physicians and counting. So let's dive into things here. FHO and FIG income streams. FHO versus FIG model. So both models have fixed payments and variable payments. So that's basically how we've broken things down here just as a visual. So fixed payments within the FIG model is the comprehensive care payment. And then within the FHO model, you have the comprehensive care payment and the base rate payment. The base rate payment is really the bread and butter of the FHO. It's a higher dollar value than the comprehensive care payment. Within the FIG, you also have your fee-for-service billings, which take up the majority of billings within that model, patient enrollment incentives, the Preventive Care program, and bonuses and premiums across 5 separate categories. In the FHO model, you have your fee-for-service billings, patient enrollment incentives, Prev Care, bonuses and premiums across 8 categories, but you also have access to access bonus, shadow billing, and CMEs. And in the FHO model, between 70 and 75% of all income within that model is fixed, and that's done through the comprehensive care and base rate payment, and that's based on the roster. Roster is incredibly important within the FHO model. So a little bit of an illustration of the income breakdown within the FIG and the FHO. This is really where you can see that there's a large discrepancy basically between fixed income within the FIG and fixed income within the FHO model. Some of the nice things about fixed income are the fact that you have income predictability each month, especially with where clinics often take a percentage of the billings. It is nice to always have a sort of a baseline understanding of how much income is going to be coming in on a monthly basis. Allows for a little bit more flexibility of time as well. Now, the average Cirrus client, we've done a lot of work with transitioning physicians from the FIG model to the FHO model. We see an average increase of around 18% when transitioning between models. Now, this is an illustrative view of the FHO income stream breakdown. So along your left-hand side, there are the 6 different revenue streams available to you within the FHO model. And on the right, you can see what the typical distribution is. Now, the capitation payments, that's the piece that's coming from your roster. That's the age-sex breakdown of the patient. And that is anywhere, we typically see 70 to 77% of that total income is guaranteed. The rest of that income, as you can see in numbers 2 through 6, are variable payments based on performance. We're going to walk through these in a little bit more detail as well. So let's start with capitation payments. So capitation payments within the FHO model, it's the monthly payment that is provided for each rostered patient and is adjusted based on age-sex. A 65-year-old female earns more through capitation than a 17-year-old male, for example. It covers a basket of services consisting of 126 codes, which represent the majority of comprehensive care services to patients and is referred to as in-basket services. These are things like your run rate services, your A007s, your A003s. All other services provided to rostered patients that are outside of the basket are paid at 100% of the fee-for-service value. For example, that diabetic care, congestive heart failure, smoking cessation, all of these pieces are on top of the capitation payment. So it's incredibly important to be really familiar with the out-of-basket codes in order to drive revenue. Now the capitation payment breakdown, you'll see along the left-hand side here, there is the dollar value. That's how much income you earn from a patient over the course of the year. And along the bottom, you can see that these are the different age categories. So the older you get, the more income you earn from those patients on the roster. And the reason for that is they typically demand more service and more complex care. So once you're over the age of 90, you're earning almost $600 from those patients because they're demanding a lot of care and a lot of your time. The average patient in Ontario today earns about $215 per year. So the financial impact of a roster increase. This is the easiest, most predictable way to increase income within the FHO model. Now, I know that there's a lot of people that feel as though they're sort of stretched, so the rostering up isn't always the answer, but what we want to make sure is that the patients that are rostered to you, that you have listed as rostered, the Ministry of Health also has listed as rostered to you. So just take a little bit of a look here. I mean, even if you're missing 50 patients, or if you're looking to roster an additional 50 patients, that's around $10,000 per year that would be guaranteed income that would come through that capitation payment on a monthly basis. So consider this when you're looking to increase income. Ways to do this, though, is we will also want to, above and beyond just going out and finding net new patients, we want to ensure that the patients you're already seeing are on your roster. This is incredibly important. So if you take your patient enrollment reports and the base rate payment report within the FHO model that you get on a monthly basis from the ministry in that manila envelope. So if you look at that list, cross-reference that with the people that you have listed in your EMR or your billing and scheduling software as rostered, you want to cross-reference those and make sure that they match. More often than not, they don't. So what we want to make sure is that everybody that you have listed as rostered, the Ministry of Health also has listed as rostered. So you can see that even if you were missing 25 patients, that's an additional, on average, $5,300 that you would be just leaving on the table. Also, when you are rostering net new, or if it is patients that you found through this reconciliation exercise, don't forget about submitting the patient Q codes, such as the Q013. $6,000 minimum a year for the first 60 patients. So make sure that you're submitting this along with the Q200 when you are rostering. And if they are for patients that you currently see that aren't listed as on your roster, when you do the reconciliation exercise, you can retroactively roster 6 months. Now the capitation payment within the FIG model. Based on my experience in speaking with a lot of FIG physicians will have large rosters, just like in the FHO. So let's say they have 1,800 patients, but only 500 of those may be rostered. Because the majority of income comes from fee-for-service, there just is less of an emphasis on making sure that the patients are rostered. But it's an incredible opportunity for you and really money being left on the table that you are eligible for. So the capitation payment, as you saw in the illustrations in earlier slides, it represents a much smaller percentage of overall income. However, FIG physicians should take advantage of guaranteed income available through that comprehensive care payment because it's an average of $35 per rostered patient. Now let's look at that. If that's 1,000 patients that you currently don't have rostered to you, then that's $35,000 that's currently being left on the table. That's why I say very important to make sure that the patients that you see on a regular basis are rostered to you. And roster management. So we assist greatly with roster management. As you can see, it's a great income generator and incredibly important to really understand so that you're getting the right mix of patients on your roster. So we ensure rosters are well managed through regular reporting. And we also provide reports on which patients are currently being seen by you but are not on your roster. So we can actually do that reconciliation exercise for you. And we'll also compare fee-for-service billings for high usage of enrolled patients to ensure the right sort of roster composition. It's really about the right balance. I was recently speaking with a physician that had majority of her patients were a lot older, so she wasn't seeing very many patients a day because they were demanding just so much time. So when we actually took a look at her roster, because it was an elderly population, a lot of the patients, she sort of has a higher rate of patients passing away, so she needs to roster up a little bit more. So we're trying to fill that roster with some, sort of younger families in order to really get the right sort of mix and composition that's really good from a long-lasting predictability standpoint. And as I say again, just to drive my point home, the capitation is the greatest generator of income in the FHO model. Incredibly important to make sure that your roster is tight and that you're doing that roster reconciliation twice per year. Now, fee-for-service and roster optimization. So fee-for-service within the FHO typically makes up around 8% of overall income, and it's a great revenue driver because anything that you're billing fee-for-service for that's out of basket is going to earn you on top of that capitation payment. Now, within the FIG model, of course, the fee-for-service billing is the majority of the way that the income is earned. So let's look at this in the FHO in terms of two separate buckets on a high level, enrolled patients and non-enrolled patients. We'll take it down a level from there. Let's start with enrolled. So enrolled patients and in-basket services. This is where you're paid the shadow billing portion for this service. So you're getting 15% of the fee-for-service value for everything that is listed as in-basket. For example, AO07s that walk through your door. Enrolled patients out of basket. This is where really the rubber hits the road in terms of billing optimization, because this is where you're not only receiving the capitation payment for the run rate services for providing to patients on your roster, but you're also really being incented by billing outside of the basket for more complex care, for example, diabetes. Now, for non-enrolled patients for in-basket services, this is one that is often, whenever I meet new groups that are either interested in transitioning from FIG to FHO or FHO physicians that are maybe working a lot at, they're working in their practice and maybe also at a walk-in clinic. In-basket services for non-enrolled patients, you're of course getting the full fee-for-service value because they're not enrolled. However, in-basket services to non-enrolled patients are subject to a group-wide hard cap. Now, to explain that a little bit further, each physician within the FHO is granted $60,000 approximately per year toward their hard cap. It's a group-wide cap. However, if someone exceeds their $60,000 limit and another physician is well under that $60,000, then no one is penalized. So in our experience, working with many groups across the province, we have not seen groups come dangerously close to the cap. Most physicians, and the reason for this is that most physicians have their patients rostered, so these in-basket services wouldn't be attributed to non-enrolled patients. Most of those patients would already be enrolled. And the reason for that is that in terms of just a general rule, you typically earn more by having the patients on the roster versus off. Now the cap is in place, just from a high level, the cap is in place in order to prevent and or discourage physicians from keeping frequent flyers off of their roster and patients that are rarely seen on the roster. Now, non-enrolled patients out of basket services is, of course, just the fee-for-service value. So important to sort of be aware of the different ways in which you're paid fee-for-service for enrolled patients and non-enrolled patients. Out of basket services. So, as I say, a great revenue driver for you. The key areas for this that are across majority of practices across Ontario would be diabetic management, smoking cessation, and after-hours billing. If you do nothing else within the FHO, we want to make sure you're billing effectively for these key pieces. Now, the Cirrus fee code sheet, this is a resource that we provide to all of our clients, and it is an extension of the SGFP billing guide, but it's specific to the FHO model. And not only on this is the common out of basket codes, which you can see just in the snapshot here, but on the back, we also have listed of all of the different special premium categories and all of the codes that contribute within each of those categories as well. Let's look at diabetes just as a sample. K030, if you're to bill for one of those, a diabetic assessment, you can bill that up to 4 times per year. Then you can bill the Q040 once you have all of the information, which is another $60. So maximum per patient annually, if all of that diabetic care is being billed for properly, is just over $215. But also remember that if these patients are enrolled and the average capitation payment is also $215, all of a sudden the value of that patient doubles. So diabetic patients, incredibly important that they're rostered and that the care that I know you're already doing is being billed for properly. Because I can't stress enough that I know, having gone into tons of practices across the province, people are doing this work and not necessarily billing for everything that's owed to them. Now, the number of patients within a typical practice size, on average of around 1,500, there's typically anywhere between 120 and 140 patients with diabetes. So that's full revenue potential of $26,000 to $30,000 a year on top of that capitation payment. Smoking cessation is another sample that we should look at. So the E079 is an add-on to an assessment code billable once per year, and the K039 and Q042 billable twice per year. Want to make sure that when you're having this conversation that you're billing for it. More often than not, the conversation is happening, but the bill isn't being submitted. You just submit the assessment code. So we want to make sure that you're actually billing for this activity because it really is just revenue left on the table for you. So although a little bit tricky because you're having to really think about this one as an add-on code, all codes can be billed in addition to an assessment where appropriate. So maximum per patient annually is around $100, and typical number of patients that smoke within a roster size of around 1,500 would just be over 150 patients, which is an additional $15,000 per year. So this is the ministry's way of incenting FHO physicians to basically provide that more complex care to patients that are rostered. And they do that by having these types of programs land outside the basket so you receive the full fee-for-service value. After-hours billing is another incredible opportunity for both groups. Q012 is a 30% premium, but it's for enrolled patients only. So making sure that those patients are enrolled is incredibly important in order to gain access to this great program. So it's a 30% increase on the fee-for-service value for the codes listed here on the right-hand side. And we want to make sure that this is happening during a scheduled after-hours block. That's the important key piece. Scheduled or unscheduled visit. Now, access bonus and outside use. This is specific to the FHO model and a program that is often a little bit confusing, and a lot of different FHO groups handle this program very differently. So let's walk through it and just let's try to understand it first, and then we can go through some best practices. So net access bonus, in terms of overall income generation within the FHO, is around 5%. So the bonus itself is paid based on the level of access a physician provides to their overall roster. It's a bonus incentive to ensure that the patients that are rostered to you are coming to your practice to receive that primary care that's being paid through the capitation payment, those 126 fee codes. The average potential is around $62,000 per year per physician. Now, the way that the ministry comes up with your bonus potential is based on your roster size. It's typically around 20% of your salaried income. That's what kicks out the bonus potential. So it's different for each practice, but on average, if you have a practice around 1,500 patients, it should be around $62,000 per year. Now, that $62,000, however, is reduced dollar for dollar for FHO in-basket services provided to enrolled patients outside of the FHO. What that means, for example, is if one of your rostered patients walks into a walk-in clinic and has an AO07, that AO07 value is then reduced from the $62,000. It's also paid out based on group performance. So this is really where, in the FHO model, it really turns into a little bit more of a team sport than in the FIG, where it's still a little bit more of an individual sport. Negative members of the group will impact those who are positive. For example, if one physician within the group, let's say they have the $62,000, out of that bonus potential, at the end of the day, they have $5,000 left of that. Now that should be money that's owed to them and should go into their pocket. However, if another physician within that group is negative $5,000, they don't get that taken off of their RA in any way, but they will wipe out the bonus potential for that other physician, so both physicians will receive nothing. A lot of groups put rules in place through their group governance agreement in order to basically mitigate against potentially one physician with a negative access bonus wiping out bonus potential for each group. Everybody sort of deals with this a little bit differently, but interesting that it really is a group-wide performance. So outside use management risks, it's a difficult program. A lot of doctors I speak with say, you know, Andrea, I don't know how I can control patient behavior. I mean, I have these patients rostered to me, but I didn't agree to work 24/7, and we certainly don't encourage that. But outside use, some of the management risks are, as you know, it's hard to control patient behavior. You can't guarantee that if somebody works downtown Toronto and there's a walk-in clinic right beside their office and they're sick, that they're going to necessarily come all the way back uptown in order to try to book an appointment with their family doctor. Also, this is key. Patients are unaware of the impact when seeking care outside. I think we all would agree that most patients don't know what the FHO means and don't realize that if they go to a walk-in clinic that it's having a negative impact on the FHO practice. No open appointments. This is also a problem. So if your office is booked solid every day and there's no open appointments available, there's no way you'll be able to accommodate same-day emergency visits. Referral patterns. The referral patterns, and what we mean by this is if you're referring to another physician that doesn't have a GP designation, then they will contribute to outside use. A key important piece is that a Royal College certified specialist does not contribute to outside use. So if you're referring to a Royal College certified dermatologist, that won't contribute to outside use. However, if you're referring to a CFPC certified physician that has a focus in dermatology and they're billing family practice codes without the ministry GP designation, that will contribute to outside use. And patients are really unaware of the after-hours care that's available to them. More often than not, with the physicians that I've worked with, people have the conversation at day one when you first sign and enroll, and you go through the process of talking about the FHO, what it means, I'm your doctor, you have that nice conversation, and then no one ever really speaks about the FHO again. So it's important to really try to drive that message home that there is after-hours care available to them. So some outside use best practices. The first thing we want you to do is analyze the data to determine which patients to move from the roster to fee-for-service. You can de-roster a patient, and it doesn't mean that you're no longer their healthcare provider. You can still see them, but you'll just see them on a fee-for-service basis instead of being that prepaid way by having them on the roster. We also would want you to de-roster retroactively 6 months in order to recoup any outside use activity that's happened during that period, or to the earliest date of outside use if you think 6 months is too far. This is an important point, that outside use is a daytime access issue. It does not mean that there's not demand by your patients on the weekends. That's not what it means, but the A888 is billed on the weekends, and that doesn't contribute to outside use. So that's always why we see outside use drop on a Saturday and Sunday. Doesn't mean there isn't patient demand, but just in terms of this program, that when the A888 is billed, it doesn't contribute to outside use. So OU is really a daytime access issue. We want to ensure that same-day urgent appointments are available. And ensure front office staff understand the FHO program. This is incredibly important. Your staff are your greatest asset to deliver that message on an ongoing basis to patients. More often than not, staff, again, we have that discussion initially and then we don't have it again. The patients need to hear this a number of times before they'll start to really understand what it means to be a patient in the FHO and what benefits there are to them by going to the after-hours clinic versus going to a walk-in. And that sort of took away from my last point here, which is educate patients on what it means to be in the FHO. By educating patients that, if you come to the after-hours clinic between 5 and 8 p.m., I'll get a report from the physicians or my colleague. I'll know what was prescribed to you. I'll know what the interaction was, versus when you go to a walk-in clinic, I have no idea basically what was done or what was, what was prescribed to you during that activity. So that's a key message that really does resonate with a lot of patients, but again, it's about delivering it, and that's often what's missed. We also want you to be aware of red flag codes. Now let's talk about that a little bit further. So patients who use the following services are usually chronic contributors to outside use due to ongoing relationships with other GPs. For example, if general assessments are popping up on your outside use report, and you also, I should mention before we jump into this, that you get your outside use report every month by the Ministry of Health, comes in paper format, or for some people it may come electronically. You need to look at that, because that is the only way of knowing who of your rostered patients have gone outside for care within that month. So it's a very interesting report. So the general assessment, if that pops up in AO03 for a full physical, it could be a sign that they're starting a new relationship with another practitioner. That's not a typical code that would be billed in a walk-in clinic. Special visit codes also you should really be aware of those if those are popping up on your outside use reports. And focus practice assessment codes. These are some of the biggest that really are high dollar value codes, so they really rack up outside use and drive down that bonus potential on a monthly basis. Sports medicine is one, allergy, pain management, sleep, addiction, diet clinics, and all of these really contribute to outside use. Palliative care codes, this one often shocks people because if it's one of your rostered patients has been admitted to a hospital and it's a CFPC certified doc that's billing family practice codes, that will contribute to outside use. And psychotherapy codes is another big one, and one that we see that is ongoing, because once that relationship is built, we can really see that it's an ongoing pattern. So the way in which we assist people with managing their outside use is through our proprietary strategy and software. So what we do is we actually take those physical outside use reports or electronic reports and put them through a software program that we've developed. And from this, we can determine the patient's outside use patterns and trends. We analyze that data to determine which patients to move from the roster to fee-for-service. This is what's really difficult to do based on the Ministry of Health reports. They don't aggregate the data for you month over month. So you may be able to see that you've had a patient that's gone outside for care, but it's hard to know at what point they've negated the financial benefit of being on the roster. Educate patients on what it means to be in a FHO. We also can assist with the marketing and strategy outreach plan for this, and ensure frontline staff are delivering key messages about access. I was working with a physician that within their FHO governance agreement, the group did have to, anybody that was negative after a 6-month period had to pay back the dollars that they were negative. She was the only physician within the group that continuously had to pay back. So she came to me wondering what she could do in order to try to improve her outside use. We took her data, ran this report for her, and unbeknownst to me, during that time, she actually went, looked at the physical Ministry of Health reports, and just sort of eyeballed it and de-rostered based on who she thought were her really chronic contributors. She de-rostered 40 people retroactively. We ran her actual Ministry reports through our software, did the cost-benefit analysis for her, spit out her top 20 patients that were taking down her access bonus. Not one of those 20 patients were on her original list of 40. So that is what is incredibly difficult to pull out from the Ministry of Health reports. So within our actual report, here's a sample of a couple of the pieces of information that we'd be able to provide for you. One, on the left-hand side, are the codes that contribute to the outside use. And on the right-hand side, the day of the week that is contributing to outside use. You can see that even though this is a sample, Saturday and Sunday are the lowest. That's because the A888 is billed on those days. Monday through Friday, we always see more outside use happening, and typically higher at the beginning of the week. So what the report actually shows you are what days of the week peak your outside use in order to be able to schedule your appointments appropriately. Maybe your outside use peaks on a Monday, so maybe we want to keep some more open appointments on a Monday afternoon when people call in first thing in the morning to try to get an appointment. So it's about scheduling strategies once we have this information. What codes contribute? So not only are we going to show you what codes, but we'll show you which patients are landing as the top 20 users of outside use, as well as what codes are being billed on them outside of your practice. Top 20 patients, and at what point does it make sense to see somebody on a fee-for-service basis? So it doesn't mean you are no longer their healthcare provider. You absolutely are. You're just changing that administrative relationship. Let's talk about shadow billing. So shadow billing within the FHO typically earns around 6%, or anywhere from $20,000 to $30,000 per year. Now, it's an in-basket services provided to enrolled patients and is paid out at 15% of the fee-for-service amount. It's called the blended fee-for-service premium on the RA, and is also referred to as accountability billing by the ministry. We strongly encourage everybody to shadow bill for all in-basket services you provide, as it gives the ministry visibility into the level of care you're providing to rostered patients. Without this, there's really no way of anybody knowing the level of care that you're delivering to those rostered patients. So it's not only a good thing just to do just in terms of due diligence, but you're also paid for it. So if you're not doing it, it's really money left on the table. Now, Prev Care and special premiums, both available in the FIG and the FHO, around 2% of total income within the FHO model. Now, your preventative care program, you do have up until the end of September to bill for this activity. There's a 6-month scale date on the last Ministry of Health fiscal year that ended March 31st. So I encourage you to look at your preventative care target reports that you've received from the Ministry of Health in order to bill for this activity. This is one of the main ones where everybody's doing this and people often aren't tracking and billing for it. Special premiums and CMEs also available. So special premiums, there's a total of $36,000 in bonus potential within the FHO and $28,000 within the FIG. Typical physician earns anywhere between $2,000 and $4,000. Obviously, if you don't provide care within all of the categories, you're not going to be able to capture that full $36,000. Now, CMEs are paid, as you know, in the FHO only, and a total potential of $2,400 per year, and the typical physician does max out on that bonus potential. So the special premium bonus categories. So these track, unlike the Prev Care program, these track automatically with the codes that you're billing. So within your RA, you can see every month how many codes you've submitted that count toward these different categories. So all of these are eligible for the FHO, and those highlighted in red are just for, or are the only ones that are available to the FIG physicians. So again, sorry for a little confusion there, but all of these, all 8, are provided in the FHO, and only 5, those highlighted in red, are the ones that are available to FIG physicians. So I encourage you to become very familiar with the codes where you do provide the care. Obviously, if you don't do labor and delivery, we're not going to encourage you to start doing labor and delivery. But if you do palliative care, or if you are doing prenatal or hospital visits, you want to ensure that you're using the proper codes in order to kick out the bonuses, because you're already doing that work. CME Credits. So this is a snapshot here on the bottom of where you can find this in your RA and what it looks like. So each fiscal year, you're allocated 96 credits, $2,400 per year of CMEs, which compensate you for 24 hours. 80 of the 96 credits can be Main Pro M1s, the Q556, and the remainder have to be Q555 or Q557. This is the one piece that people often are a little bit lost on, because 80 of the 96 can be Q556. And you can carry forward up to 96 unused CMEs from the previous year. And when we always say year, we mean Ministry of Health fiscal year, April 1st to March 31st. So this is where, on the bottom here, you can see on your array the total credits that are available to you within each different category. Now let's walk into a little bit of a case study. This is a physician that we worked with. She came to us was running her practice, wanted some assistance in order to really be able to take advantage of what was available to her. So we started working with her through our Ontario Practice Development Program. So the OPDP program, as we refer to it as, is a one-on-one consulting program. So a little bit of background about this physician was in June of 2012, this physician joined the program to optimize practice efficiency and improve revenue within the FHO. Basically, she came to us and said, I think I'm doing things correctly, but I'm not entirely positive, and I want to ensure that I really am being paid properly for the work that I'm doing. Her motivation was to increase income, work-life balance, and flexibility. Her roster size was around 1,100 patients with an annual income of $262,000 per year, average working hours around 45 per week. So this is our baseline. This is what we started with. So the first thing that we do as part of this program is we perform another piece of our software, which is called the Cirrus Performance Index. And it's a report that identifies specific areas in need of improvement in the physician's practice. So what we do is we'll look at your individual performance across the 6 FHO revenue streams or across the revenue streams within the FIG model, and can sort of compare and contrast you between other physicians within the province. We need this in order to determine sort of what the baseline is of your practice before we really jump in and come up with an individual program. So some of the goals for this particular physician were to improve understanding of the mechanics of the FHO model. Without this understanding, the rest of it is sort of over everybody's head. We really need to make sure that we understand the mechanics and sort of the baseline before we would jump into additional pieces she needed assistance with. So we did this by doing on-site educational seminars for the physician and the staff. Incredibly important and invaluable that your staff fully understand the FHO model and know how to support you within it. Quarterly review of RA and billing information. So we would do this in order to ensure we were on the right track after we came up with this 12-month plan for her. The second goal was to improve access bonus within 1 year. Now, she was negative access bonus and had been for quite some time. So really, she was sort of the mind that, you know, I don't think I can be positive. You know, I provide a lot of care. I have open appointments. You know, I'll work with you guys, but I'm not convinced at this stage that you're going to be able to move me into a positive access bonus position. So what we did was reviewed, and we did some cumulative tracking of her outside use reports. So the ministry reports were sent to us every month, and we provided her with quarterly outside use management reports. So the one I was speaking about in earlier slides, we did that 4 times per year to show her the days of the week, the codes, the patients that were contributing. And we came up with a bit of a plan to reduce outside use based on some of our best practices. The next layer down was the optimization of special premiums and bonuses. So needed to provide strategies and best practices to increase the Prev Care program within her office, and a year-long tracking and semi-annual reporting of special premiums. So what we do is, with all of our clients, we provide them with semi-annual reporting of the special premium targets. So we can show you how many in each category, you know, how many labor and delivery codes have you billed, how many more until you reach the bonus threshold. Just a little bit more visibility in terms of where you currently are at within that fiscal year. We streamlined the FHO administrative and ministry liaison activities. So we took over that sort of administrative requirements for the FHO operations. We do not take over the actual billing, but we do assist the physician and the staff with any type of ministry liaison activities. Ongoing assistance and maintenance for staff and physicians. This is one that, although it's at the bottom of the list, is really one that most people really take advantage of, and it's an invaluable service. We're a team here, so we provide staff and physicians with relevant ministry updates and on-request assistance. We have subject matter experts that work on our staff, so as questions come in, we can sort of send those to the appropriate people in order to get the right information back to you. So let's look at her access bonus over time. This is really interesting. Remember, she said that she never thought that she was going to be able to be positive. Well, you knew I was going to prove you wrong. So in January of this year, she was still negative 37%, all the way until finally we got to March, and she was positive for the first time. April, May, June, we have been improving. And as of June, she's receiving 88% of her bonus potential every month. So this would be money that would go directly into her pocket. And all we had to do was to come up with some of our strategies, as well as look at the patients that are on her roster that were really contributing to high outside use. So it is possible. The physician performance metrics. So this is the first thing within the very first, when we first start working with a physician, as I say, we look at the baseline within each category, and then so that we can get a basic understanding of where the income is being generated from. Capitation payments, as you can see, went from $195 to $220. Fee-for-service billing actually went down, and the reason for that is because a lot of her patients that she was seeing weren't rostered. So all of a sudden, once we moved them into the rostered category, there was less that was falling within her fee-for-service bucket. But that income is now guaranteed. Two things of note here are Prev Care bonuses, so just was doing the activity, wasn't billing effectively for it, and special premiums. Again, doing that activity, often money left on the table. So she had an incredible increase. Since engaging Cirrus, the physician's annual income has increased by just over $40,000 and increased by 14%. The increase has resulted in an 837% return on investment in working with the Cirrus team. Important to note here that we don't take a percentage of any of the earnings. We charge a flat fee, so anything that you push anywhere, any percentage that you gain is yours. OPDP, physician performance metrics. So just want to give you a bit of a breakdown in terms of the amount of hours that we worked with her to do this activity. So FHO administration, setting her up, going through paperwork, going through her roster exercises, 51 hours since last summer. FHO education, 39 hours, and outside use, 21 hours. So total amount of hours saved was 111 hours total. So she saved on average about 1 day a month that would otherwise be spent on administrative and practice optimization activities. So we were able to basically take that on for her. And because we're the experts in what we do, it doesn't take us as long, and we can just move you and your staff through this program quicker. So some key highlights of performance improvements were increased income through FHO education, surrounding Prev Care, special premiums, and out-of-basket billings. We identified patients who were not enrolled and worked with the ministry to clarify missing capitation payments. So really obtain that income that was owed to her. Assist with improving outside use to attain positive access bonus from a projected negative access bonus of $2,000. And acted as ongoing liaison with the ministry, has assisted her with a locum as she wanted to have those on during the holiday season, and ongoing billing inquiries from her and her staff. So the OPDP program is a 12-month program. It begins, as I say, with an analysis of your current practice to obtain a baseline. From there, we have a goal assessment strategy that we come up with you. If you are within 5 years of retirement, that's going to be a very different goal strategy than if you are a young female physician with, with 2 kids and you're trying to balance your time. And so a very different goal strategies, obviously, for anybody, depending on where you are within your life cycle. Customized 12-month program to help you and your staff actualize what's available to you in both the FIG and FHO models. And the ROI on this, as I say, the average income increase is 15% overall, with an average ROI of 800%. On average, 15 hours per month saved on administrative and practice optimization activities, and a flat fee is charged, not a percentage of the gain. So in summary, some things I want to highlight for you, some key takeaways that you can take back with you today and start working on. Ensure that your roster is managed properly and that the patients you are seeing are actually on your roster. Capitation payments are the largest source of revenue within the FHO, and I should mention in the FIG, often just completely not captured within the FIG model. Review the bonuses you are eligible for in both the FHO and FIG and ensure you're billing effectively for that care. So what codes contribute to palliative care, to serious mental illness, to hospital codes? We want to make sure that you know which codes contribute in each category and that you're billing effectively for that care you're already providing. Set up a smooth Prev Care program with your practice to maximize the bonuses available to you. Just around 13,000. Typically people are doing this. You're doing your mammograms, you're doing your PAPs, you're doing your colonoscopies or FOBTs. So make sure that you're billing and tracking properly for that activity. Be aware that outside use is a daytime access issue, not evenings and weekends. And you do have the ability to de-roster in the FHO retroactively upon making an informed roster management decision. So that's what we had planned for you today. I will be following up with everybody that's been on the webinar today individually. So please let's set up a time to discuss your questions in your practice in further detail. And we have some contact information up here if you would like to connect with me directly. But as I say, I will be reaching out to you. And I thank everybody for joining today. Thanks.
Awesome. Thank you, Andrea. We do have a few questions, and we have a bit of time, so we'll try and go through the questions. But as we both mentioned, we can definitely follow up individually and answer any of the questions that you do have. So we'll go through. We have about 3 questions here. Sure. So the first one, can you remind us about the A888 code? Really, it should be emergency room equivalent, so all visits on the weekend should not be considered AAA?
Yeah, it's unscheduled, so walk-in clinics are billing it. It's emergency visits that are unscheduled. So that is what is being billed during that activity.
Okay, so focus practice code should not cause outside use if the person has a focus practice designation. We see it on the outside usage, but it should not actually come off. Please clarify.
And that's correct. So if somebody is GP focus designated, and it's not just that they are sort of self-identifying themselves as GP focus designated, you actually have to apply for a designation from the ministry. There's a list of all of the GP designated doctors in Ontario within each different category. So for example, sports, psychotherapy. And if those patients are popping up on the report, my sense is that the doctor doesn't actually have the designation or perhaps lost their designation because they weren't billing enough within that specific category. So that would be something that I would certainly follow up with that physician on or connect with the Ministry of Health in order to get the list of practitioners that do have the GP focus designation.
Great. Second question, is it true that Q012 can also be billed on a visit on Friday afternoons?
Yes, in the evenings between 5 and 8 p.m.
Perfect.
So from the ministry's perspective, the weekend starts Friday evening.
Great. Can you comment on the proper use of the A888 code within a FHO model?
The proper use of it? Not sure I fully understand when it should be used. It's for an unscheduled sort of urgent visit.
Okay. Can these slides be made available to us? Yes, the webinar will be recorded, and you can view the webinar, the recorded webinar on Cirrus's website as well as Nightingale's website. Next question, if in the FHO, is there any limit for outside basket?
Out-of-basket billings? No. And the reason for that is because the ministry is trying to incent you to provide that complex care. So So no. So if you're really billing properly for your fee-for-service, out-of-basket codes, I mean, that's a great income opportunity for you. So no, there's no cap on that because they're trying to drive that behavior. Within certain, I should give a bit of a caveat. Obviously, you saw within the diabetes, I mean, you can only bill certain codes X amount of times per year. But overall, in terms of the out-of-basket billing, there is no cap on that.
Great, thank you. Is there a flat fee variable by practice size? I guess in terms of your services that can...
Or what flat fee?
I believe that they mean flat fee for your services, and I guess that's something that can be talked about offline.
Yeah, absolutely. I mean, we work with groups and we work with individuals. I mean, we do apply a bit of an economy of scale to those groups. It's really based on, I mean, we work with some entire FHOs where we take over all of the banking, scheduling. I mean, we really are assisting with running the actual FHO. And, I mean, on the other hand, sometimes we're working individually with physicians, just with them and their staff on their specific practice and sort of billing related items. So it's very much dependent on the type of service that you're looking for.
Perfect. So similar question related to the outside or billing outside the basket. If a person in a FHO but also sees patients at another clinic that is fee-for-service, is there a limit?
So that is the hard cap. So that's what I was talking about, the $60,000 per year. But it's for enrolled and it's for in and out of basket services. So if you're a FHO physician, for example, and you're working at a walk-in clinic, if you are billing just standard codes, you're likely contributing to your hard cap, but you're probably not exceeding the hard cap. Everything is listed on your RA, so you can pull out how much you've billed per year. I actually think it might even show up on the FHO group RA, so you can see what the group-wide cap is, and then it gives an aggregate total of all of the physicians within the group and where you're currently sitting as you sort of creep closer to the cap.
Okay, great. One question, can the Cirrus billing guide be made available to the people on the webinar or only for those that purchase the analysis?
So it is a piece that we do provide to our clients. Again, I'll be following up with everybody directly. So if somebody would like to obtain one, I'm happy to mail one out. That's no problem.
Okay, perfect. We'll take one last question.
Sure.
Similarly, with the outside of the basket, does it include only walk-in clinic patients? I'm not really sure what that means, but we can definitely follow up with everyone individually and have a conversation based on specific questions that you have regarding the specific topics that were covered in the webinar. So don't fret, we will be following up with everyone to answer any of those questions, and that way you can speak with someone in person and get all those questions answered. So with that, we will sign off today. Thank you again, Andrea, for joining us, and everyone on the webinar. We look forward to seeing you and speaking with you after this webinar, and we hope that you join our next webinar with Andrea, which is on September 25th at 12 p.m. Have a great afternoon, and thanks again.
Thank you.
Bye-bye.